So now I want to introduce and bring to the podium Dr. Greg Albers, and Dr. Albers is director of the Stanford Stroke Center here at the university. He's also a professor of neurology and neurological sciences. He's going to be talking about mechanical thrombectomy for stroke and what happens when regulatory approval, reimbursement, and clinical research collide. Dr. Albers.
Thank you. It was a great pleasure to be invited to this very distinguished group and spend some time with you. I was asked to broaden my topic a little bit beyond mechanical thrombectomy and acute stroke to talk about systems of care for TIA. One thing not on the schedule here is discussing prevention of deep venous thrombosis. And I'm a little concerned about you guys because it's been at least 2 hours of restricted venous return. So, and my talk is scheduled for 45 minutes. I'm going to cut it a little shorter, but I think maybe 30 seconds of up on your tiptoes, the blood flowing. The other thing it should do is increase cerebral blood flow, which would be needed for this talk because a little bit of audience interaction is going to be requested here. All right, good.
Thank you.
So we're going to start off with acute stroke, talk about that for a little bit, some interesting things that are happening. And then we're going to pick up a little bit on the themes that you heard from Amy and her colleagues about more cost-efficient care for patients who have neurologic symptoms that sound like they could be due to brain ischemia. So intravenous TPA, this is our big treatment for stroke. This is a major breakthrough in stroke care. It was approved in 1996 by the FDA with a 3-hour treatment window. That means we have to be within 3 hours of when the patient was last known to be well. This has been studied in incredible detail, and it is a highly cost-effective treatment. In fact, it's been called one of the most cost-effective treatments in all of internal medicine. So pretty impressive. The sooner you give it, the better. You heard about that from Amy, and we're very impressed with groups like what's been done in Helsinki and are trying to get this treatment in the US administered much more quickly. But disappointing, you have such an effective treatment, look how many patients are getting it. At some stroke centers like ours, it's about 20% of the patients who are eligible for TPA and get treated. At other places, they're not too effective in getting this medication to the patients who need it. 1% treatment rates, even less. Tremendous disparity across the United States in who's getting this very effective treatment. So, what are the other options for these patients? What are the options when somebody shows up and it's been beyond 3 or 4 hours since they were last known well? This is the Mercy retrieval system. So if you look at this as a catheter with essentially a corkscrew on the end. So the same principle in which you pop the cork out of your California Cabernet or Chardonnay can be used to pop the clot out of the brain that's causing a stroke. This was actually developed by a French researcher, so he's probably thinking about a Bordeaux or something, how he gets access to the wine. Same thing, you've got the clot in there, and you want to get it out. So very interesting, of course, that devices come to market in a very different way than a pharmaceutical like TPA. You don't have to do a randomized trial to prove efficacy and safety to get a device on the market. But you have to have some evidence to convince the FDA that you should get a 510(k) clearance, which means that you put the device on the market and you say it's basically safe to do this task, and the task is pull the clot out of the brain, but you leave it up to the doctors to run research to determine who should be treated, how much benefit is there cost effectiveness. You can't have cost effectiveness without knowing that there's true effectiveness. And 510(k) clearance means that you can get on the market without knowing if there's true effectiveness. And that's exactly what's happened with these devices. The way they got on the market was you do a cohort study. 100 consecutive patients come in with a big stroke, up to 8 hours after symptom onset. You go in and try to pull the clot out. About half of the time they're effective in getting the clot out, and those half of the patients seem to do quite a bit better than the half when they were unable to get the clot out. That leads to a 510(k) clearance, devices on the market, encouraging data, but we can't do any cost effectiveness on that because we haven't proven that we've made patients better, or which patients have been made better and which have not. So Now it's time to do a randomized trial. These devices are not only on the market, but being reimbursed at a pretty nice rate from CMS. Not inappropriate because it's very expensive, right? If you're going to take a patient to the cath lab and they're going to spend time in the ICU, you're going to have to reimburse the hospital more to do that. If you reimburse the hospital more to give IV TPA, right? You have to pay for the TPA, there's more monitoring, there's more work. So there is a difference in what the DRGs are going to reimburse the Medicare patient with a stroke, depending on what you do with them in the hospital. Now add this to the complexity of now I need to run a clinical trial to determine, are these devices truly effective for helping my patients? So you can imagine that you're in the emergency room, your loved one is in the midst of having a large stroke, and the doctor comes to you and says, there's a large blood clot in your brain of your loved one here, and we have an FDA-cleared device, it's called the Mercy device, which can probably pull the clot out. That could be a good option. We could try that. The cath lab is ready. Let's go ahead. Or we've got a clinical trial where we can randomize 50% chance of getting this device and 50% chance that you get the control. And we see if we can prove that the device is effective. So it's time to make your decision. What will it be? Mercy or no mercy?
Now remember, the French would be thank you or no thank you. So.
That's right. And the no thank you is the response that you're going to get. Imagine trying to do these trials. These trials have been incredibly difficult. And imagine what type of patients get enrolled. If the doctor thinks this is a good candidate to go to the cath lab, they're not even going to offer the study. If the doctor thinks, well, this patient is debilitated, elderly, there's some reason that I think the cath lab is not a good choice, maybe I'm going to offer the treatment. So this can lead to tremendous bias in the results of the clinical trials. And in fact, just last February in the New England Journal, 3 randomized trials, the only 3 randomized trials attempted and completed, were reported. And they were all negative. All negative. Basically showing no difference between either just giving TPA to those who came in early or just doing standard medical care to those who came late versus going to the cath lab and using one of these not inexpensive devices, which is going to result in a not inexpensive DRG for that hospital. So here's the question for you. We've got all randomized trials negative. We've got the devices being used through 510Ks, being reimbursed through CMS. What do we do now? 3 choices. One is that we just stop paying, suspend reimbursement for this treatment, which has not been proven to be effective. Number 2, change the reimbursement so that only patients who enter randomized trials, which would have hopefully less biased enrollment, would be reimbursed. Or 3, let's wait for more data to come in. There are some randomized trials going on. Let's not be too premature in making a change. So let's see what this very distinguished group of audience members say. How many would vote A? Stop reimbursing. We got some choices. How about B? Reimburse only if we get some good quality clinical trials done. And how about C? Let's wait. Don't disturb status quo quite yet. We don't want to give up those big DRGs. Okay, so B is the winner. B is the winner, and that would be something CMS would have to decide to do, which would clearly help us in getting these trials done. Some of the private payers are already starting to get very persnickety about paying, right, for these unproven treatments. So I think it's really a fascinating situation where we can just see from the acute stroke setting that the way that devices come to market versus drugs is very different, and that has a huge implication on stroke research, a huge implication on helping to determine what's a cost-effective treatment. And I think we do need some changes in the system. I like the vote that you guys gave that before we let something onto the market without efficacy data, it would be nice to mandate some good quality clinical trials. We're going to shift focus a little bit away from the acute stroke intervention and talk about this stroke code that is occurring right at the time that you sat down at the meeting. In the emergency room, you get a call that there's a 61-year-old woman, pretty healthy, but had some pretty significant stresses in her life recently. And she came in with a 2-hour episode from 8 a.m. to 10 a.m. of left-sided weakness. Blood pressure is 160/90. Neuro exam is normal. Routine labs look good. Non-contrast head CT is normal. Okay? Resident sees the patient, calls up Amy Tai, who's the attending, and Amy says, what do you think? Is this patient had a transient ischemic attack? The resident, being uncharacteristically honest, responds, really can't tell, sounds like it could be, but how do I know? There's a lot of other things that can mimic. She's been under a lot of stress, something sounded a little atypical. Amy heads over, agrees some of the features are atypical. She does something called the ABCD2 score, which comes up with 4. Says, I think it also might be a TIA, but hard to be sure. Let's get an MRI scan. So here's the MRI scan. Somehow in the transition from PC to Mac, this poor patient's brain got So this is not what an MRI normally looks like. But this patient has a dot here on diffusion-weighted imaging, which indicates there's been some irreversible injury that has just occurred to this patient's brain. So even though the symptoms are completely gone, there has been an acute injury, an ischemic injury occurring in the brain tissue of this patient, where we were wondering, was it ischemic or not? Blood vessels look normal, and now the question is, what is the diagnosis? TIA or stroke? How many think this patient has had a transient ischemic attack? How many people think this patient has had a stroke? So that's interesting. When I went to medical school, I was taught if you have the symptoms and they disappear within 24 hours, it's a TIA. You guys weren't taught that? Because this patient is normal 2 hours into it. I was also taught that if they have a brain injury like this, that it was a stroke. So it's a little tricky here. Is this a TIA or stroke? And how should we be defining TIA, which is important as we talk about how we're going to be cost-effectively preventing stroke and working up these patients. So a number of us were concerned about this discrepancy in the definition of transient ischemic neurologic event, and said the definition that we learned in medical school probably should be changed. But how do you change a definition you learned in medical school? It's not particularly easy, right? A definition that's been around for decades. So fortunately, the New England Journal was willing to help us along and publish this provocative paper in 2002 saying that this patient should be called a stroke patient, which is interestingly what you guys all voted, because a stroke should be what happens when there's injury to a brain. And now we've got technology that can tell us, even though the symptoms are gone, this patient had some brain injury. So if there's evidence of infarction, it should be a stroke. If there's no evidence of infarction, let's call it a TIA, and not get hung up on some arbitrary time window of 24 hours. Cardiologists don't say how long angina can be. They say when you damage the myocardial tissue, it's a myocardial infarction. If you don't, it's angina. So the idea was that TIA and stroke should be defined in a more similar way. So you publish the article, you get lots of people to disagree and write in editorials about why you shouldn't change definitions, but eventually the American Heart Association endorsed the new definition of TIA. So that was nice to be able to make some change, which seems to have filtered down out to the crowd here. So we do have a new definition. And this definition can help us a little bit in prognosis, as we'll get into a minute. The other thing that can help us in prognosis is some simple clinical scales. So we talked about the ABCD squared score, which is basically the risk factors that you guys are all working so hard to get under control. Does the patient have these risk factors? And what that's really going to be is a little bit of a surrogate for, was this a TIA or was this not a TIA, right? Because patients with vascular risk factors who have transient neurologic episodes are more likely to have a true event. Patients with no risk factors might be more likely to have had a nerve compression or a migraine, or maybe it was an anxiety reaction from all the stress. So this helps us a little bit in predicting what the future rate of stroke is. It also probably helps us in predicting who truly had an ischemic event and who didn't. And here's some work that was coming out of work from UCSF and Northern California Kaiser, as well as a team with Peter Rothwell in the UK, showing that based on the score, so here are the different 0 to 7 ABCD scores, and the different colors are the stroke recurrent rates at different time intervals. So if you look at the pink bars, that's looking at what's the chance this patient is going to have a stroke over the next 48 hours. And that's kind of important, right? Because if somebody is just about to have a stroke, may not be the best idea to send them home, particularly if there's nobody around to watch them, right? That could be considered bad form. It could be considered a medical legal issue. So if we look at the pink bars, we can see that if your score is down there in the 0 to 3 range, it is incredibly low. It would be hard to imagine that you could be cost-effective hospitalizing all those patients for this incredibly low risk of having a stroke. But as you start to get up to larger numbers, you get into ranges that would be concerning to send these patients home. So this is one component of the puzzle. Another issue is, can we add to it? Can we put some imaging on top of that clinical ABCD risk score? And research that we participated in suggested, yes, the imaging can be helpful. For example, the patient that we saw here today in our example had a diffusion lesion. That was that MRI positive lesion. And we can look for her. If we say what's her ABCD score and what's her MRI, we get an answer that maybe she's got a 5% risk of having a stroke in the next several days. Whereas if her DWI was negative, her risk would have been less than 1%. So again, this could help us as we're trying to make decisions on how we're going to manage these patients, how soon they need to be completely evaluated, and how safe it would be to send them back to Modesto, where they may not have somebody who's watching them and may not be close to a hospital that's ready to give TPA. So lots of things to think about. Another issue that we can consider is about how accurate are we in being able to make a call. Did a patient truly have an ischemic lesion, which is going to require all the treatments that this group is so interested in? Statins, aggressive hypertension management, diabetes, etc. Versus did they have another diagnosis, which could lead to completely different treatments, treating their migraine rather than aggressive risk factor reduction. So this is some of the data looking at if you have transient neurologic symptoms and somebody in the ER thinks that you're having a TIA, how likely is it that that MRI scan that we showed is not going to show evidence of ischemia? Well, it turns out that if you look at patients within the first 3 to 6 hours of their event, they're having 3 to 6 hours worth of symptoms. It's about 30% who will be diffusion positive, therefore we know they've had an ischemic event, like our example, and about 70% will be diffusion negative, meaning we're not sure. Maybe they had an ischemic event, maybe they didn't. Now, as you go up to an episode that would last 24 hours long, it should go to basically 100% diffusion positive and 0% would be diffusion negative. But that's not what we see. We see that if you look at patients who've had 18 to 24 hours worth of symptoms, diagnosed in the ER as probably had a TIA, only 50% of them have evidence of ischemia on their brain imaging. So what does that tell you? It could tell us our imaging isn't that good, and if we had more sensitive image, maybe we could pick up 100%. Or it could tell us something else. Our diagnosis is not correct. That we thought it was a TIA, but it was something else. There's a lot of things that mimic TIA. Lots and lots of things that can look like a TIA. And by the time all the dust is settled and we see them in clinic, our conclusion is it was a nerve compression, or it was a metabolic problem, or it was something drug-related, or it was benign positional vertigo. So it tells us that we need some better technology, could be better imaging technology. It could be something that the cardiologists have that we don't have. Troponin, right? Troponin is very helpful to determine when somebody's having myocardial ischemia or not. EKGs are very helpful for that. So we need more technology, and that's an important research issue. Can we get a blood test that will tell us this truly was an ischemic event versus this was a non-ischemic mimicking event? Okay, so participated with the National Stroke Association a couple years back in trying to make some improvements into how TIAs are managed, systems of care for TIA. And this fits in really well with what Amy talked about, that probably doesn't make sense to hospitalize everybody with a TIA. It's expensive to hospitalize patients with TIA, and hospitals that have very tight beds would much rather fill their beds with patients where we're really doing more for them than having them sit around, wait for imaging tests, wait for echoes, etc. So the goal was to bring in a lot of different people, groups like this, and say, for different health settings, what's the best possible way to handle TIA patients? And a lot of these are the issues that came up. Bed availability, right? If I have very restricted bed availability in my hospital, I want the sickest patients where we can do the most. I don't want to be saying no to transferring in some patient that maybe we can go to the cath lab and open up their middle cerebral artery or give them IV TPA and really do a lot for them if I've got somebody who's sitting around for 3 days waiting for their TIA tests. What's the status in your emergency department? ED that's full, you don't want people sitting around with their TIA for 8 hours getting all their workup done while they're sitting in the ER. Do you have a stroke unit? What's the payer mix? Do you have stroke experts available? And what kind of wait time do you have to get the vascular imaging that these patients need to make sure they don't have a tight carotid stenosis that needs to zip off to the emergency room right away? So when you look at how different it is in all these different settings, you can imagine that a solution for one place is not going to be the solution for the other. But the current status doesn't make sense, because if you look at how TIA patients are treated, there are places, academic institutions, who still admit all of their TIAs. Everybody with a TIA gets admitted. We have some in the Bay Area that work that way. We have other institutions that admit virtually no TIAs, and some that do something in between. So that huge discrepancy, there's got to be a problem, right? It doesn't really make sense that this condition should be all admitted or all not admitted, depending on what hospital you roll into. And that's where the CERT group is really putting a lot of thought into this. So the recommendations from the National Stroke Association was, it is absolutely fine to do this as an outpatient, but you better think about how you're going to do it to make sure that you don't have the situation where a high-risk patient on a Friday afternoon is sent home for the weekend without a way to be handled rapidly if they were to have a stroke. So the idea is that you're going to have a protocol, you're going to think about how you're going to do this, and it is probably not a protocol that's going to treat every TIA patient the same. You need to do something to identify who's at high risk and who's at low risk and treat them appropriately. And if you're going to do it as an outpatient, you better have availability of these tests to be done pretty quickly. Because if they're going to have a clot in their heart that you're going to pick up on an echo and you don't do it for a week, that's a problem. Or if they're going to have a high-grade stenosis that needs to go to the OR and you don't find out for 2 weeks, that's a big problem. So we've been interested in this for a long time. One of the issues at Stanford is that we do have very tight beds, and we would much rather bring in sick patients than say no to a referring hospital who wants to send somebody to us. So we noticed that the TIA patients were taking up a lot of bedtime at Stanford, and they are the lowest priority. Right? If you're waiting to get an MRI scan on your TIA patient, and you've got somebody who comes in with a spinal cord issue or acute stroke or virtually anything, the TIA patient gets bumped and bumped and bumped. So the disgusters that were talked about, the patient is disgusted, the doctor's disgusted, the guy's in there doing work on his laptop, when can I get out of here? So we developed this triage protocol called 2 ACEs several years ago to try to address that. And I'm not really going to go into all the details here, because we'll try to get you guys back on time with your schedule, but the idea was that there are some patients who could bypass the ER altogether. That the primary care physician could get the information from this patient and determine from very simple, non-imaging, non-laboratory-based criteria that this patient could be seen in clinic. And as long as the TIA clinic can see them within 1 to 2 business days, bypass the ER. The other is the patient comes to the ER. You're going to do something to look at how tight the stenosis in their blood vessels would be. You're going to do this ABCD squared score, and you're going to make a decision that a good chunk of these patients can leave the emergency room promptly and be seen within a couple of days in your TIA clinic. And you're going to have a subset of patients who were worried about these. We've got something out of the scores or the vessel stenosis or some other aspect of the story that tells us this is a high-risk patient, or there's nobody to watch this patient, or they live far away, and we're going to admit what will turn out to be a subset. So using this protocol, we went from admitting 75% of our TIAs to admitting 25% of our TIAs, which was a big, big difference. And then we needed to show, well, if we do that big change, is it going to be safe? If we handle patients in a TIA clinic, is the stroke rate going to go up? Are we going to have patients who have strokes and don't get handled appropriately? So the hypothesis was that we were going to have less than a 2% stroke rate at 1 week and less than 5% at 90 days, and that would be very good compared with all the data that was out there, such as the data that led to the derivation of these ABCD scores. So here was the results of the study. As I said, 75% of the patients were able to be handled without hospital admission, and they did extremely well. Their stroke rate at both 70 and 90 days overall was less than 1%, and this compared very favorably with what the expected stroke risk for this population would be when you control for ABCD scores. So it suggested that an outpatient strategy can be cost-effective and safe. Here's some of the data, looking at the numbers. Again, the details are not critical here. We looked at a subset of the patients who had Medicare reimbursement and said, how much is it costing Medicare if we handle these patients only in the clinic, ER to clinic, or ER to hospitalization, and probably wouldn't take a lot of leap of faith to figure out that it's cheaper not to show up to the ER, and it's cheaper if you go from the ER to the outpatient clinic than if you go from the ER to being admitted to the hospital. So you're going to save some money. So conclusion is that this is really something that needs further attention, figuring out a model that's going to fit for different types of health systems that will handle TIA patients in a more rational manner, which does not lead to admitting all of them, but admitting the ones that are most likely to need admission. The limitations of our study were a relatively small sample size. We need to see this done in other places. Sometimes the patient doesn't return to clinic, so that's an issue too. If the plan is I'm going to do all my evaluation as an outpatient to free up the ER and not hospitalized, what if that patient doesn't come back and you miss the opportunity to find out they had a high-grade stenosis? And we have some insurance issues still. We can't have anybody show up to the Stanford outpatient clinic. One has to have some method of paying for the Stanford outpatient clinic. So clearly it's not as simple. And I'm going to close with an alternative model that we've been looking at more recently to address some of these limitations and also just look at doing it a different way. And that is the clinical decision area approach. And this again was part of what Amy presented. And we've been running this the last couple of years at Stanford, which is still incorporating the TIA clinic, but trying to capture the critical diagnostic information before they leave the hospital, ER facility. And that is having the ER expanded into an area that's called the CDA. It's like a chest pain clinic, but it's for patients with TIA or other neurologic issues can fit into this group. It's a 24-hour stay. You get them out of the main ER that's so crowded, and you get the test done very rapidly. So there's got to be an agreement with your imaging group that for these patients, we're going to get the MRI and the vessel imaging done within 6 hours. And that's the way that you can get these patients evaluated with the critical tests very early. And if you see something very concerning, you can convert them to inpatient. If you don't, then they can have the rest of the evaluation finished up at the TIA clinic. So we've been looking at this model and have also been very encouraged that this is going to be an effective and cost-saving way to handle these patients. And what Amy's group is proposing is that not only TIAs could fit into this, but your minor stroke patients. Minor stroke patients across the country pretty much uniformly admitted. But if you have a minor stroke patient and they go through this type of CDU evaluation, I think we can save a lot of money and that these patients can be handled very well. So it's my last slide, call to action slide, which is saying that I think we've learned a lot about stroke, both in the acute treatment as well as prevention, but we need to be able to convert that into cost-effective models of caring for these patients. Right now, we are not terribly cost-effective in caring for either our acute stroke patients or evaluating and managing our TIA patients. So I would encourage everybody in the room to think about this within your own setting and challenge yourself to think about whether you could be handling your TIA patients and acute ischemic patients in a more cost-effective way. Thank you very much.
Thank you, Dr. Albers, very much. Terrific presentation, and I think outstanding examples of how we need to rethink totally how care is delivered. That it can be done in lower cost settings. It requires some imagination and the ability to really look at subgroups and the tools of predictive analytics and so forth. Those patients that can be treated differently, they don't all have to go directly to the hospital, but it also requires quite a bit of organizational change and institutional change to accommodate these kinds of changes. I think we saw all of that in Dr. Albers' presentation, so thank you for that.